Well, hello. My name is Jodi Skulls, and I am your instructor for the MBLEx review course. We are all here studying to pass the massage and bodywork licensing exam. Yeah. And this course today, we are talking about the kinesiology of the knee. So we are talking about the structure and the function of the knee joint. Let me assure you, you're going to know more than you'll ever need to know about the knee. In fact, if you go on to take continuing education and it happens to be involved with pathologies of the knee or injuries of the knee or recovery of the knee, you are going to have a very strong foothold, very strong foundation on what we're studying. So, our class is in 3 parts. And those 3 parts are a test-taking strategy, learning, the actual content and learning, and the third part is dissecting questions. And our members in the Patreon community overwhelmingly uh, uh, gave us feedback that they love questions. So today we have a full 10 questions to dissect together. So we have a lot of work to do today, but it's going to be fun. We're together. We're studying. Let's get started with the test-taking strategy for today. And I love it that Alicia put in our comments that she has developed such strong study habits from being a member of this program. And that is my message for you today. Do meaningful homework. One of the main reasons maybe that you joined, but a lot of members join this community is because they don't know what to study. Maybe they bought a study guide or they've got their books from school or they've been using an app. And it's like, okay, but how do I know that I'm studying the right stuff? We have developed a very specific program for you of what to study. Every Monday, there is an announcement on the Patreon website, on your app, and that is what to study for this week. And we are bringing you through 12 sessions to prepare you to pass our practice exam. Yeah. And that's how we know you're ready to take the MBLEx. We know you're ready to take the MBLEx when you pass our practice exam, the MBLEx simulation exam, when you pass that 3 times with a 70% or better, and you've finished in under 2 hours. So this is the goal, ladies and gentlemen. The goal is to take that simulation exam and pass it in under 2 hours. And you pass with a 70 or better. And I want to see you do that at least 3 times. Yes. And then we'll deal with all the other stuff. But the learning part, as far as what to study, that tells us you've got a body of knowledge that is sufficient to take the MBLEx. Now, there's all sorts of other factors that play into test taking, right? There's anxiety, there's feeling overwhelmed. There's all sorts of things that energetically we also deal with. We give you the tools for, and that's other test taking strategies that I share with you throughout these 12 sessions. And so part of your preparation is to know what you're studying each week. Yeah, yeah. And that allows you to do meaningful homework so that you have a strategy. You know, okay, once I get through these 12 sessions, once I get through these 7 classes, once I pass this exam 3 times, boom. And then you can always direct message me and myself or Tara will answer. Am I ready? We can even do a 20-minute call, 1-to-1. Am I ready? If your friends are wondering, am I ready? Let's find out. Yeah. Part of what you're doing as you work through this course material is you are coming to class, you're watching these recordings. This is a part of meaningful homework, but also you've got a strategy for the rest of the week, right? So our strategy has you taking quizzes, has you taking practice exams. Yeah. And that strategy keeps you from that strategy keeps you from feeling overwhelmed or keeps you from feeling lost. Yeah. All right. That is my test taking strategy for you today. Do meaningful homework. So I love it that you're coming to class. I love it that you're watching this, but this is only one brick in the wall that you are building. It is only one piece of the foundation. There's other factors that help to prepare you to confidently and calmly, at least partially calmly, pass the MBLEx. Let's move into our learning for today. Here we go. The structure and function of the knee. At times, I'm going to be hiding all the pictures here, and that is because I don't want it to interfere with what you can see. So the structure and function of the knee, I want to give a shout out to Scribe, SCRBD. That is a slide share site that gave me some of my images for today. And it specifically was Dr. Zinat. I used a bunch of his images today, so thanks for that. All right. Let's take a look at what the knee actually is. The knee consists of the tibiofemoral joint and the patellofemoral joint. So technically, the tibia and the femur come together. We always call it the knee, right? However, the scientific name is the tibiofemoral joint. And from a medical point of view, the patellofemoral joint is also considered anatomically a part of the knee. So the kneecap, the patellofemoral joint, so the patella is sitting on top of that femur. We could compare that to the scapulothoracic joint, right? Where there's not really an articulation there. It's actually just the shoulder blade that glides against the rib cage. Likewise, the patellofemoral joint isn't a traditional joint. It's the kneecap gliding over the head of the femur. All right. Let's take a peek. Here's the femur. Here is the tibia. And here is the kneecap. So this is considered the knee, the tibiofemoral joint, and then the patellofemoral joint. And you can see how this patella is actually gliding over the femur, right? Let's briefly talk about what type of joint the knee is. The knee is a synovial joint. Synovial joints are what we think of as joints. When you and I talk about joints, it's what we think of as joints. These joints are considered diarthrosis, so they're freely movable. The other types of joints in our body are not as movable. They're either semi-movable or they're considered immovable. So examples of those would be our pubic symphysis would be semi-movable. The sutures in our skull would be considered immovable. So diarthrosis means they move. And synovial are the 6 joints that we think of when we think of our joints. All right. I liked this picture of the knee joint because you could see a bunch of the different structural characteristics of the joint. And this is, so you've got a joint cavity, and that really is what determines a synovial joint, that there's a joint cavity. And it contains synovial fluid, therefore its name, synovial joint. This joint cavity is cushioned with that synovial fluid, which is secreted by a synovial membrane. I wanted to introduce you to cartilage. This is called articular cartilage because it articulates, and articulates just means touches or talks to. So this is articulating cartilage, and this is the knee again. So this is the femur and the tibia. Yeah. So I liked this picture as far as the structure of the knee joint. We'll get a lot more pictures of structure of the knee joint. Yep. Good. Nice big picture of that. Again, there's the distal end of the femur with the articulating cartilage. That white stuff is the cartilage. And then the blue stuff is the synovial fluid filling that joint capsule, produced by the synovial membrane. That's this little outside part here. Good. Another angle, I didn't think this was quite as clear, but it is an actual x-ray of a bone, of a knee. So you can see the femur, the distal end of the femur. Here's that patellofemoral joint. We've got the tibia here. You can see the tibia is larger in its proximity in this image. And then we got the fibula hanging out over here. So we're kind of looking at kind of a back picture of the knee joint. So here's the proximal end of the tibia, the proximal tibiofibular joint. Yeah, nice little anatomical structure here. Okay. The tibiofemoral joint, our knee, is formed with these two big condyles. These are what are called condyles. They are on the distal femur, so on the bottom part of the femur, and they articulate. So where that knee joint comes together, the tibia, you see, it's got a relatively flat surface. So it's not like that ball and socket joint, say in the hip, where things are really snug. In fact, the knee as a hinge joint is sometimes compared to the elbow, which is also a hinge joint. But on the elbow, we have a hard stop with the elbow. We have that boney landmark, the olecranon process, the elbow. But in the knee, sometimes the knee can hyperextend a little because there's nothing behind it. But I wanted you to get a sense of these condyles, right? These are the condyles. This is where they articulate with the tibia. Got a little peek of the fibula here. This is the tibiofibular joint. One place that the tib-fib articulates, touches, or has a joint. But you can see the head of the tib is relatively flat. Good pictures, huh? So I wanted to give a shout out to the doc because he came up with some good pictures for us. I mentioned the patellofemoral joint. It is not a traditional joint like we think of, but you can see here, it is formed by the patella floating in the quadricep tendon. We're going to talk a little bit more about the patella in just a moment. That this is the distal end of the femur. And you can see here it's in this location. Beautiful picture of the kneecap, that patella. Now the patella, I'll talk about the patella in just a moment. We're going to look at three sides of this knee joint. We're going to look at the lateral, the medial, and the front. So we'll look at three sides of this knee joint so that you can get an idea of the movement and the structures that support that knee joint. I started to say that the knee joint it's really held in place more so by a lot of tendons and muscles. You'll see, take a peek. The movement that occurs, the kinesiology of the knee joint occurs, there's two movements and two planes. Two movements, two planes for the knee, okay? The easy one is flexion and extension. You'll think it's easy until we actually cover it. But flexion and extension is what we think of as the knee joint. All right, sorry, this little speaker thing here is Want to make sure you can see all the fangs. Okay. So the easy one, again, is the flexion and extension. That's what we think of. But there is a little bit of internal and external rotation to the knee. This is what we're going to be looking at. Lots of muscles, lots of tendons. For a point of reference, 2/3 of the muscles that cross the knee also cross either the ankle or the hip. So there's a super highway of stuff happening. So about 2/3 of the muscles that are involved with the knee either are primary movers of the hip or also are crossing the ankle. So there's a big connection between ankles, knees, and hips. For example, if someone has tight ankles, they won't be able to do a proper squat, keeping their heels on the ground. That is because of the kinetic chain, the connection between the ankles, knees, and hips. And so as body workers, as massage therapists, when someone comes in and says, oh my gosh, I've got some knee pain, I've got some hip pain, you want to work all three. Address their concern with where their pain actually is, but make sure to address the ankle and the hip as well. There's just a really big connection between the three of them. And we're going to reiterate again that the stability of the knee, it's really more so based on the soft tissue, the ligaments, the tendons, the muscles that surround that knee. Very much like the shoulder. When we compare the shoulder to the hip, the shoulder is held together by a lot more ligaments, tendons, and muscles. The hip is a deep ball and socket joint, right? The shoulder is also ball and socket, but it's not quite as lock solid stable. More so depends on that soft tissue. What did I want to say about this? Okay. I think that's what I wanted to say was that the hip and the shoulder, so the hip and the shoulder are both ball and socket joints. The elbow and the knee are both hinge joints. Difference there too. So this massive femoral condyles, right? If you saw that on the MBLEx, what would you think? These massive femoral condyles. What are you talking about? You're just talking about the distal end of the femur. Remember, these are the condyles. And you can see that's just not it's not like that ball and socket. So held in place by ligaments, joint capsule, meniscus, and other large muscles. You can see those layered on here. Here are the muscles. This is actually turns in, is that the quadricep? Yep. So this is the quadricep tendon. And I wanted to point out, see how the patella has this ligament? It attaches a bone to a bone. Sometimes it's called the patella tendon, but it's really the patella ligament. So depending on what you get on your test, just know that's the one below, because this is the quadricep tendon. The bone is actually embedded into the quadricep tendon. We'll see another picture of that momentarily. All right. I don't think you'll ever see the word osteology on your MBLEx, but just in case, osteo means bone. Osteology is the study of bones. So bones, the bones that make up the knee, the distal femur, the proximal tibia. We do need to take a look at the proximal fibula and the patella. Technically, it's the tibiofemoral joint. The femur is not weight-bearing. Excuse me, femur, Jesus. The fibula is not weight-bearing. So we're going over all this anatomy because you really do need to understand it to understand the mechanisms of the injury, of the pathology, and really the best way to treat it. So condyles, maybe this will help. I like images. So condyles comes from the Greek word that means knuckles. And they're those large rounded projections that are part of the femur. There's a lot of anatomy on this slide. You don't need to know it all. We're going to talk about the major movements. We're going to talk about the most important parts. Please do not weigh yourself down with all of these bony landmarks. Now, there are some that you need to be familiar with, and we'll speak to those in just a moment. For example, every now and then you see pes and serenus. The reason we care about this bony landmark is because it's where the gracilis, sartorius, and semitendinosus is actually, that's where they touch. That's where they're attached. But mostly the vocabulary I want you to be familiar with is condyle and epicondyle. We're going to go over this groove here in a moment because now and then that does come up on the MBLEx, this intercondyle groove. And there's some attachment points here. But let's move along. So the intercondyle groove, why do we care? We care because a couple ligaments go through that groove. So again, right here, under the dotted line, is this intercondyle groove. It's a part of the knee. So in that groove, in the notch, sometimes it's called the groove, sometimes it's called the notch. So on the back, so the posterior inferior, and I'm throwing in a few words here so that you kind of start to imagine, posterior inferior, distal femur, and the notch, that notch is a passageway for the ACL and the PCL. Now, do you have to know all about the anterior cruciate ligament? You do not. But you do need to know they exist. And you do need to know when you see ACL or PCL or LCL, where are we in the body? So please don't go down the rabbit hole on attachment points. Just need to know where in the knee and make a great guess as to those attachments. Let me show you the picture. So here's the notch, the groove, and we're going to pop in the tendons. So here we are again, the condyles, the head of the tibia, and here's this ACL, the anterior cruciate ligament, the PCL, posterior cruciate ligament, and then the M. Oh, that's the medial meniscus. Yeah, the lateral. On the lateral meniscus. Good. Oh, there's the LCL. There we go. LCL, outside collateral ligament, medial collateral ligament. So we got 4, right? We said we were going to look at the front, the sides, and the back of the knee. These are all terms, anatomical terms, to be familiar with. Okay, so that you can understand the nature of an injury, you can understand the nature of an MBLEx question. Nice picture of the meniscus here too. I want you to notice that the meniscus is not under the patella. The patella is embedded into the quadricep tendon, and we're going to take a look at that. But the meniscus actually cushions this joint, is part of the cushioning of the knee joint. Right, so a few bony landmarks here for you. Again, they serve as the attachment points for the MCL and the LCL. You don't need to know origins and insertions of these cruciate ligaments. So we have 4: anterior cruciate ligament, this anterior cruciate ligament, posterior cruciate ligament, medial cruciate ligament, lateral cruciate ligament. Pretty straightforward, right? Okay. It's just when you start to see some of these words, if you see them on the MBLEx, medial femoral condyle. Oh my goodness, what is that? As you know these anatomical terms, slow down, sound it out, figure out where you are in the body. Good. The medial tibial plateau. And again, so the tibia has plateaus, they're flat. The femur has condyles, they're knuckly and big. And you can see here, I want to point out the fibula is not weight bearing. That joint is the tibiofemoral joint. This image more so to one side of the screen because this is a left knee. So if you were looking at your client, this would be this is the left knee. Kneecap, MCL, LCL, anterior cruciate ligament, you can't really see the posterior, and then the meniscus. So we get the fibula involved in this party because of the LCL. Its attachment point, the lateral collateral ligament, is actually the head of the head of the fibula. Yeah, beautiful. There we go. So here's your tibial tuberosity. Tibia, right? And it's that bone. And we're going to talk about this because it's actually the site, that tibial tuberosity is the site of some attachment points. The tibial tuberosity is a bony landmark. It's an attachment point. It's also the site of some pathologies, some problems for the knee. It's a little bony protrusion, and it looks like this. Right here, the front of the tibia. A little bit later on, we're going to be talking about Osgood-Schlatters disease. And I'm going to talk again about that tibial tuberosity, because this is where the problem starts. All right. Oh, we're here. Osgood-Schlatters disease. So activities, so in kids, this Osgood-Schlatters disease actually is mostly found in young men. So younger boys, but like the ages of, say, 11 or 12 to 18. And because they get so involved with sports, they start running and jumping and playing soccer and just being uber athletes. Now and then, that force from them being uber athletes generates a little bit of muscle pull on the tibial tuberosity and the patella tendon. And so what ends up happening is they get this pain right below their knee. And little chips of the tibial tuberosity are actually flaking off. That's technically what Osgood-Schlatters disease is. And you can see this tibial tuberosity. And I'm not going to go so far down the road on the Osgood-Schlatters. I wanted you to know it actually usually fixes itself as the young man grows and develops. But it's not uncommon in adolescent boys and girls, really. Girls, much more so now, are also becoming uber athletes. So little fragmentations of the tibial tuberosity, that bony protrusion, and yeah, and that's why they get that pain just below. And I think I have a picture of it. Yep. Part of the concern is that it can affect the growth plate that is there. So if that growth plate gets damaged, then there's other complications. So they do keep a good eye on that. and an x-ray with my little arrow. This is what's happening here, Osgood-Schlatters disease. Okay. So again, one more time. Big quads, lots of jumping, lots of running, lots of developing that muscle. Little fragments of the immature little tibial tuberosity are pulled off, and it's called Osgood-Schlatters. And you may have heard of it when you were in massage school. It's one of those pathologies that we cover because people come to us with their athletic children saying he's got knee pain. Well, he needs to be seen by a doctor. Yeah. And there's evidence of it right away is if that, look at this one. You can see this isn't a 12-year-old, I don't think, but this is evidence of Osgood-Schlatters, that type of bony protuberance. All right. Be familiar with proximal versus distal. The proximal fibula is the attachment point of the lateral collateral ligament. This articulation so there's a little joint on both ends of the tibia and the fibula. So the closest one to the knee, of course, is the proximal tibiofibular joint. It is not a part of the tibiofemoral joint. It supports the lower leg. It is not weight-bearing. It can be about the same length, but it does tend to be very slender. And again, the reason we care about the fibula, it's an attachment point for the LCL and also biceps femoris. Reminder, biceps femoral. Oh, we're going to be talking about the movements here of the knee in just a moment, but wanted you to be very familiar with the anatomy. This is what, okay, so biceps femoris also attaches at this, it's called the fibular head. Nice big picture. The patella is the largest sesamoid bone in the body. And in the past, people have asked, hey, what tendon does the patella insert into? And this is a picture of the patella, but all of the technology says that let me go back here for a moment. All of our anatomy says, it just says the quadricep tendon. Now, I would have said rectus femoris because that's the central part of the quadricep muscle. But over and over again, when I did the research, it simply says that the patella is within the quadricep tendon. So, and because of that, it's actually really movable. It goes up and down. You can kind of wiggle it around, a little bit. Yeah. If your leg is in a neutral position, the quad isn't activated, you can actually move that patella around. And there can be some abnormal gliding, which can cause some pathologies of wear and tear. But just know that it is embedded within that tendon. That's what makes it a sesamoid bone. So sesamoid bones are always embedded into tendons. And the tendon, the patella, is the largest. So, fun fact, some of the stability of the knee is from the fit of the patella. It actually helps to hold things in there. Here's the picture I'm going for. The quadricep tendon, the embedded sesamoid bone, the patella, and technically the patella ligament. It's a ligament because it attaches a bone to a bone. We come in here and see the IT band. The IT band also lends some stability to the knee. We're looking at an anterior view. You're seeing vastus lateralis, the quad on the lateral aspect. You're seeing vastus medialis, VMO, on the medial aspect. If you've ever watched the Tour de France or seen a professional cyclist interviewed, you'll notice they've got these great big quadricep muscles, right? The one on the medial side, vastus medialis, the VMO, is strong because when it is not strong, it tends to have that kneecap gliding in a funky way. Quadricep tendon, the patella ligament. And you've already been introduced to cartilage. Here's another nice view of it. Quadricep tendon, patella ligament attaching, look, to the tibial tuberosity. There we go. Wanted to show you the relationship between the hips, the knees, and the ankle. There is a whole science, and if you go on to become an orthopedic doctor, you will understand the science between the hip joint, the knee joint, and the ankle joint. There's very specific angles. There's angles because when these are not present, you have pathologies like knock-kneed or bow-legged. You will not need to know these names for these pathologies. They will use the more traditional names on the MBLEx. And you can see here the degrees, but you do not need to know degrees of movement, only that these pathologies exist. Knock-kneed and bow-legged. Good. So I wanted to mention that I used the doctor's slides. Some of them are way more than we need. Okay. What we do need is the movements of the knee, right? We're here to learn about the kinesiology of the knee. So the movements of the knee are super straightforward. Flexion, extension. There is a slight medial rotation and a slight lateral rotation. Let's first talk about flexion. Now, when we flex our elbow, it looks like this. Biceps brachii is shortening. Our bicep muscle is shortening, pulling our lower arm up. Flexion at the elbow. Flexion at the knee is when the hamstrings contract, the hamstring group. The hamstring group is semitendinosus, semimembranosus, and biceps femoris. So that hamstring group is contracting, and this is the nature of movement. The muscle shortens, the muscle contracts to pull, to create a lever. So here you see biceps femoris. Here it is on the right leg. Semimembranosus is in the middle, M, membranosus, and semitendinosus. When these muscles contract, it flexes the knee. Now, we're not talking about the hip. Up here is the hip bone, the proximal end of the femur is the hip joint. The distal end of the femur is the knee joint. We are talking about movement at this joint. Many members, many graduates of massage school would benefit from just pausing and remembering the difference between flexion of the elbow and flexion of the knee. Flexion and extension. We're going to be talking about extension next. All right. Flexion occurs at the tibiofemoral joint. There's a decrease in this angle. This is 180 degrees. This is 90 degrees. Remember learning that in geometry? That straight line is 180 degrees and that right angle is 90, but this is flexion is a decrease in that angle. And we cannot have extension of the knee joint without flexion. Let's take a look at the movers, the muscles that move. So we've looked at the primary movers, the hamstrings. There are a few helper muscles. We call those helper muscles synergists or secondary flexors of the knee. We're going to take a look at gracilis and sartorius, gastroc, and popliteal. The reason we care about these, not because they're synergists, but mostly because these are the muscles that slightly internally rotate that knee joint and slightly externally rotate that knee joint. The primary flexors of the knee, hamstrings. Remember our little mnemonic tool to help us remember. We've got the semi-sisters and their big brother biceps. So two semi-sisters, there's 3 hamstrings, the semi-sisters and big brother biceps femoris. Remember, we've got biceps brachii on the upper arm. We've got biceps femoris as part of the hamstring group, the posterior compartment, those 3 hamstrings. Let's take a look at the synergists of movement of the knee. Here's the difference between gracilis and sartorius. I don't know about you, but I often have to just pause and be like, okay, sartorius S. Sartorius actually starts at the ASIS and attaches, take a look. We'll take a closer look at this in just a moment. Gracilis and sartorius help to flex and internally rotate the knee. They're very much a stabilizer of the knee, but their major roles are at the hip. They are major adductors and adductors of the hip. But for the knee, they actually do play a synergistic role. Here's our gracilis, and here's our sartorius. Let's take a closer look. This attachment point is the attachment point for a number of internal rotators of the knee, but it's called the pes. I wanted to highlight this. See this? P-E-S-A-N-S, pes and cernus. That is a bony landmark that may come up on your MBLEx. Just saying. So be prepared with that pes and cernus. Pretty sure my next slide is a closer look. All right, you'll get a closer look at some point. But this little green area, it's on the medial proximal side of the tibia. So medial tibia, proximal tibia. Again, those words going to be important. This is foreshadowing. We may have them in some of our dissecting questions. All right, but that pes and cernus. So see how this word looks like the word answer? A-N-S, there was a W in here. Pes and cernus. The answer is the knee. The answer is the tibia. So associate, because we've got some other pes stuff going on, right? We've got pes planus. We've got pes cavus. Those are all foot things, low arch, high arch. This is a completely different direction. Pes and cernus, the answer is the tibia. Now at a flexor, a synergist of the knee, I wanted to just remind you of where the popliteus is. It's posterior. Remember the popliteal region is behind the knee? There is a popliteus muscle, and it does play a major role in flexion of the knee because it's when we lock our knees, that muscle popliteus muscle has to contract so that we actually can bend at the knee, can flex at the knee. So basically the popliteus helps to unlock the knee when it's in full extension. When you've locked out, it's not healthy to stand that way for a long time. It actually can cause some pathologies. It can cause hyperextension. But in that straightened position, the hamstrings don't have a lot of leverage because they've got just a few places to attach. And so that's why the popliteus is actually important as a synergist in flexion of the knee. All right. It's posterior, and it's in that popliteal region. And that is why also, let's talk for a moment about endangerment sites, right? The popliteal region is considered an endangerment site. Now, that's why working the lateral and medial aspects of the knee can feel very comfortable, can feel very helpful for your clients because there's muscles back there. We're just not putting a lot of pressure right behind the knee in that soft area. All right. Moving along, extension of the knee. So it has gone from flexion to extension. Let's take another look at that. Extension at the knee. This is more extension at the hip right now, but you get the idea. So going from a flexed position to a straight position is considered extension of the knee. What muscles extend the knee? The knee. And we'll do this now and then. I just want you to be super focused on the knee. Because sometimes when we talk about flexion and extension, graduates will go immediately to the hip. Okay, what are my hip flexors? We're not talking about the hip joint. We are talking about the knee. All right. So, real easy. The quads. The quads are the primary movers. Here we go. So, and we have four quadricep muscles. We've got the vastus, right? Our vastus group, medial, lateral, intermedial. So we got vastus lateralis, vastus medialis, lateral and medial, vastus intermedius, and then we've got rectus femoris. Again, rectus abdominis, abdominal muscle. Rectus femoris, a femur muscle. Good. Another nice look at our muscle groups. Pelvis. By the way, the sartorius starts all the way up here at the ASIS and comes down here, medial aspect of the tibia. Here's our quadricep. And see how this kind of makes it look like the rectus femoris or the intermedius is where the patella ends up, but the patella just quadricep tendon. These are our four. You do need to know your quads. You do need to know your hamstrings. You need to know their names. You need to know their locations and not necessarily their insertion points. All right. Kinesiology of the knee joint. Little review. The knee joint is a hinge joint. The two movements of that hinge joint are flexion and extension. The tibiofemoral joint is the name of the knee. Quadriceps extend the knee. Hamstrings flex the knee. And the muscles, tendons, ligaments, those all lend joint stability to the knee. All right. Are you ready to test your knowledge? Yay! It is time to dissect some questions. I will remind you to please be careful. There are intentionally tricky questions here. Take your time. Also, for the purposes of letting everyone have a chance to answer, if you would please put your answer in the chat box. But if you would wait until I say 3, 2, 1, go, before you send or share your answer. Right, let's see here. We got a couple questions coming in. All right. Ready? The tibiofemoral joint is a blank joint, and its actions are blank and blank. The tibiofemoral joint is a blank joint, and its actions are what and what? A, hinge joint, abduction and adduction. B, a hinge joint, flexion and extension. C, a ball and socket joint, abduction and adduction. D, a ball and socket joint, flexion and extension. A test-taking strategy is to eliminate at least one wrong answer. We'll be doing that today. So what do you know you could get rid of? Is there something that just jumps out at you with this question that says that's not right? Let's go ahead and get rid of letter C. Because the knee joint, yeah, that's not the tibiofemoral joint. Yeah, doesn't do these things. So get ready with your answers. The tibiofemoral joint is a blank joint, and its actions are blank and blank. Would that be A, a hinge joint, A, abduction and adduction, B, a hinge joint, flexion and extension, D, a ball and socket joint, flexion and extension. 3, 2, 1, go. Let's take a look at what our answers are. Good. Yes, Lek. Yes, Emily. Yes, Lily. Good, Dora. Martha. Excellent. Patithia. Yes, Diane. Miss V. Good. Ooh, ooh. Let's come on back. Let's come on back. Martha. Yes. Patithia. Yes. Diane. Yes. Kesha. Yes. Brienne. You got it. Amy. Alicia. Good. Maria. Good. Letitia. Yes. June. Yes. Excellent. The tibiofemoral joint is a hinge joint, and its actions are flexion and extension. Yes, careful. Tibiofemoral joint is another name for the knee joint. You saw femoral, you might have thought hip. All right. The fluid contained in freely movable joints is called what? The fluid in freely movable joints is called what? A, bursa. B, fat pad. C, synovial. D, cartilage. The fluid contained in freely movable joints is called what? Let's get rid of one wrong answer. Fluid is not, cartilage is not fluid, right? Right. Cartilage is not fluid. The fluid contained in freely movable joints is called what? 3, 2, 1, go. Let's see. Camelta, yes. Alicia, good. Brianna, Yep. Yay. Martha, yes. Emily, good. Latil, yep. Tisha, yep. Petithia, yes. Diane, yes. Lily, yes. Ms. V got it. Leck, yep. Dora, good. Kesha, yep. Amy, you nailed it. Kershaw, you got it. Raina, got it. Good. Best answer, the fluid contained in freely movable joints is called synovial fluid. Yes, synovial fluid. The sartorius muscle is responsible mostly for movement at the hip. Its attachment point, however, is blank. Is where? The sartorius muscle is responsible mostly for movements at the hip. Its attachment point, however, is where? A, medial knee. B, lateral knee. C, anterior knee. D, posterior knee. Sartorius muscle, mostly responsible for movements at the hip. Its attachment point, however, is where? Let's get rid of one wrong answer. It's not the posterior knee. It is not. Okay, the sartorius muscle is responsible mostly for movements at the hip, but its attachment point, however, is A, medial knee, B, lateral knee, C, anterior knee. 3, 2, 1, go. Martha, yes. Alicia, yes. Dora, yeah, Diane, good. Good. Ms. V, yep. Lily. Emily, yep. Kesha, yep. Latil, yes. Brienne, got it. Kersha nailed it. Amy's on top of it. Yep. Raina, yep. Maria, good. Very good. Best answer, sartorius muscle, attachment point is at the medial knee. Yes, medial knee. Remember, it's that S muscle. It starts at ASIS, comes across, and touches the medial knee. And really, if I was being technical, I should have said tibia. Medial tibia, lateral tibia, anterior tibia, or posterior tibia. On the MBLEx, you're going to see it as medial tibia, lateral fibula, anterior tibia, posterior femur. I was kind on this one. Sartorius, origin, ASIS. Insertion, remember, the PES answer, tibia. Medial knee, medial tibia. Next question. The term ACL refers to the tibiofemoral joint. It stands for what? A, anterior cartilage ligament. B, anterior condyle ligament. C, anterior cruciate ligament. D, anterior capsule ligament. The term ACL refers to the tibiofemoral joint, and it stands for A, B, C, or D. Let's get rid of one wrong answer. It's not the anterior condyle ligament. The term ACL refers to the tibiofemoral joint. It stands for A, anterior cartilage ligament, B, anterior cruciate ligament, D, anterior capsule ligament. 3, 2, 1, go. Ms. Alicia, Emily, Dora, Diane, Martha, yes. Patithia, yes. Kesha, Latilia, Lek. Good, Brienne. Good. Excellent. Everybody's getting it. Amy, Raina, Ms. V, yes, yes, yes. Best answer, anterior cruciate ligament. And I would ask that until I say 3, 2, 1, go, please do just have your answers in the chat. So you can hit enter or send or the little arrow after I say go. I want everyone to have a chance to put their answer in the box. Good. Ooh, all good, all good. Yep, we're just giving everybody a chance to think. You know what I mean? Just everybody gets a chance to think, to second guess themselves, because a lot of people say, oh, wait a minute, is it that? I second guess myself. Oh, change my answer. Nope. Jodi says, trust your first answer. So there's a whole little tug of war going on when these answers are coming up. So for some people. All right. Next question. The muscles responsible for flexion of the knee are what? The muscles responsible for flexion of the knee are what? A, semimembranosus, semitendinosus, biceps femoris. B, vastus lateralis, vastus medialis, vastus intermedialis. C, semimembranosus, semitendinosus, biceps brachii. D, vastus lateralis, vastus medialis, rectus femoris. Woo! Know your muscles of the upper leg. All right. The muscles responsible for flexion of the knee. Now, if you were going to eliminate one wrong answer, you know the answer you want to eliminate. There is something so glaringly obvious in there that you can just throw it right out. You ready to see? Let's get rid of letter C. Why? Why are we so sure we can get rid of letter C? Got biceps brachii. All right. The muscles responsible for flexion of the knee are A, semimembranosus, tendinosus, biceps femoris. B, vastus lateralis, vastus medialis, vastus intermedius. D, vastus lateralis, vastus medialis, rectus femoris. 3, 2, 1, go. Ms. Dora. Yay, Alicia. Good, Amy. Lek, nice, Diane. Good, good. Let's see. Martha nailed it. Petithia, yes. Miss V, good. Where's Miss V? Yep. Some people were second guessing themselves. Answers keep coming in. Rita, yes. Maria, yes. Kersha, yes. Best answer, boom, letter A. This is a list, my guys and gals, this is a list of the hamstring group, right? It takes a minute. It takes a minute. Yep. Yeah. So the muscles responsible for flexion of the knee. Do I have a picture? Nope, I don't. So remember what flexion of the knee looks like. It's what we call bending our knee. Flexion is bringing your heel closer to your butt. And the primary movers of flexion are those hamstrings. Good. Good. That was good. That was a good test. Good challenge. Next question. The lateral and medial condyles of the tibiofemoral joint are located where? The lateral and medial condyles of the tibiofemoral joint are located where? A, proximal end of the tibia. B, distal end of the tibia. C, proximal end of the femur. D, distal end of the femur. Whoa. We just talked about this. All right. The lateral and medial condyle of the tibiofemoral joint are located where? Now, knowing what you know after today, we can eliminate one right off the bat, right? We can eliminate letter B. The distal end of the tibia is not part of the knee. It's not. All right. Lateral and medial condyle of the tibiofemoral joint are located where? A, proximal end of the tibia. C, proximal end of the femur. D, distal end of the femur. 3, 2, 1, go. All right, let's see what we got in our chat. Oh, so I can see. Oy, oy, oy. Sorry, guys, I opened the wrong thing. Giving you guys a chance to answer, I guess. Latil, yes. Alicia, yes. Brienne, good. Yeah. Diane, good. Lily, yes. Kesha, yes. Kersha, yes. Amy, yes. Latil, yes. Camelta, huh? Martha, huh? Maria, got it? Good. All right. The lateral and medial condyles of the tibiofemoral joint are actually located at the distal end of the femur. Remember the knuckles? The big old knuckles? Those are the lateral and medial condyles. Yeah. So the knee, yes, it's the proximal end of the knee. That is the proximal end of the tibia. That is the knee. But remember, the top of the tibia is flat. It has plateaus. The condyles are those knuckly things at the bottom of the femur. All right. Oh, a picture. These are the condyles. We got other bony landmarks on the tibia that have the names condyles. But when we were talking about lateral and medial, in this case, we're talking about those suckers right there. All right, next question. The patellofemoral joint is located where? The patellofemoral joint is located where? The distal, A, the distal end of the tibia. B, the proximal end of the femur. C, the distal end of the femur. D, the proximal end of the fibula. The patellofemoral joint is located where? Do you see one we can get rid of right away? Remember, our next step is to eliminate a wrong answer. Makes it easier. If you get rid of a wrong answer, you don't have to keep reading it. We can eliminate letter B. Where is the proximal end of the femur? It's a joint, but it's not the patellofemoral joint. Okay. The patellofemoral joint is located where? 3? Oh, yep. 3, 2, 1, go. All right. Technically, let's see. All right, Dora got it. Oops, hang on, let me see. Let me make sure I got the right answer. Patellofemoral joint located at. Okay. Martha got it. Lily got it. Kesha got it. Patithia, yes. Diane, good. Amy, yes. Camelta. Oop, sorry. Amy, yes. Brienne, yes. Oh, yes, Brienne, yes. Latil, yes. Kersha, yes. Oh, 50-50 on this, right? Yeah. Okay, at least nobody. Hmm. All right. The patellofemoral joint, guys. The distal end of the femur. Remember? Patellofemoral joint. The patellofemoral joint is the patella and the femur. And that patella sits on top of the femur. It's not really a joint like we think about, but it's the distal end of the femur. Yeah. Fibula is not involved with the knee other than support. And usually we're here, there's two joints for the fibula, and that's the tib-fib joint, proximal and distal. So, all right. Next question. What exists within the quadricep tendon, highly mobile, and is at risk for an abnormal gliding or subluxation? The blank, the what exists within the quadricep tendon, it's highly mobile and it's at risk for abnormal gliding or subluxation. A, the tibiofemoral joint. B, the patella. C, the patellofemoral joint. D, the popliteal tendon. I know. Boy, is your head spinning? Okay. What exists? Let's get rid of one wrong answer. Make it a little easier on ourselves, okay? Popliteal tendon, posterior. What exists within the quadricep tendon? Highly mobile, is at risk for abnormal gliding or subluxation. Is it the tibiofemoral joint, the patella, or the patellofemoral joint? 3, 2, 1, go. Mm-hmm. It melted good. Diane, yes. Amy, yes. Brienne, yes. Ooh, got one more answer. Let's see. Kersha, yes. Alicia, yes. Look at the question. It'll become obvious once you read the question again. Maria, yes. Reina, yes. Best answer? Letter B, the patella. Mm-hmm. Why? Why is it the patella? The patella exists within the quadricep tendon. It is highly mobile and at risk for abnormal gliding or subluxation. Yes, if you've worked for a chiropractor or been to a chiropractor, subluxation means like the joint is out of whack. So I can see why you would pick A or C. But that specific description, this exists within the quadricep tendon. It's in there. Remember, it's embedded in that quadricep tendon. We mentioned during the lesson today, it was highly mobile. Yeah. All right, that's a good one. That was a good one. A little confusing. I like it when we go from not clear to clear. Mm-hmm. Mm-hmm. Good. Yep, within, exactly. Good. Brienne said she was seconds away from second guessing herself, but paused. Good. All right. Next question. In young people, excessively large and frequent quadricep contractions may overwhelm the structural integrity of an immature bone in the tibia. As a result, fragments of the immature bone are pulled from the tibial tuberosity. This is called what? A, an ACL rupture. B, an MCL rupture. C, Osgood-Schlatters disease. D, dislocation of the knee. I'll let you pause here for a moment. We're going to eliminate one wrong answer. You can read it again. in young people, excessively large and frequent quadricep contractions may overwhelm the structural integrity of the immature bone of the tibia. As a result, fragments of the immature bone are pulled from the tibial tuberosity. This is called what? It is not called a dislocation of the knee. All right. A, B, or C. A, ACL rupture. B, MCL rupture. C, Osgood slaughter. 3, 2, 1, go. Kesha, yes. Alicia, yes. Lily, yes. Diane, yes. Yes, Miss Patithia. Yes, Miss V. Good Lek. Good Maria. Yes, Camelta. Yes. Yes, Martha. Yes. Dora. Yes. Brienne. Good Kersha. Yes. Oh my God. Yay. Best answer, letter C. Osgood slaughter. Yes. So if you didn't learn that in school, now you know. Yes. Getting more bulletproof on that for the MBLEx. Getting stronger. More well-rounded. Excellent. Ooh. Ooh. And that was the last question. So much for my see you later slide. So those were our questions for today. Wow. Nice work. Good job. So think to yourself, if you've got a piece of paper in front of you, think to yourself, what are some takeaways from today? What are some things you've learned? Yeah. So more than you'll probably ever need to know about the knee, but your bases are covered for the MBLEx. Yeah. So today we took care of some anatomy and some kinesiology of the tibiofemoral joint, commonly known as the knee. I'm going to hang out with this crowd, take some questions, get some clarity, but I want to say thank you. I want to say thank you for studying. I want to remind you too that this language, this medical terminology, I used a lot of it today. This was not an entry level class today. You had to come in knowing some stuff. Yeah. So if you feel overwhelmed, that's okay. It's a part of the process. If you feel like, oh my gosh, I don't know what I'm doing, you do. You're here. You're listening. And I just want to remind you that massage therapy isn't a job. Yeah, you get a job, but it's not just a job. It's something that comes from like inside of you, like this deep desire to help people. And I'm sorry that this test is so hard. And I'm sorry we have to learn all this stuff. But you know what? I hear your vocabulary improving. I see you. I see through your answers and through your feedback that you're really grasping these concepts. So it's a perfect part of your journey. You're really meant to do the work. So thanks for putting in this work so you can do that work. My name again is Jodi Skulls. I'm your instructor for the MBLEx review course. We meet here weekly to do live classes. And so for those of you listening later, see you again soon. Going to sign off on the recording. Have a great week.